you, Dr. Vinesh, for your presentation. I I think we will take up the question answer session at the end of the session. Okay. Then we will go to the next session. That is the newer strategies introducing proteinuria and decline in GFR, especially in diabetes mellitus. In our clinical practice, every day we are seeing nearly 30% of the patients are 30% of the patients having diabetes mellitus. After 10 years, most of these patients return to us with a history of proteinuria, and we will check microalbuminuria, then overt proteinuria. All these things are very common in our clinical practice. There are various drugs available in the management of proteinuria, starting from AC inhibitors, ARBs, loop diuretics, taurines, N-acetylcysteine, keto analogs, then diuretics, aldosterone antagonist, SGLT2 inhibitors, GLP-1, and lastly Carandia. So we like to know which drug can be used in proteinuria and what are the indications of starting this drug. I think today with us, Dr. K. Naina, sir, he is a practicing nephrologist. I already mentioned he was practicing in Kochi for the last 40 years. One of the best academicians I was seen during that period, and he is the person who structured the Cochin Clinical Society, and he was a secretary for Cochin Clinical Society for I think for more than two decades. And I had the first interaction with George again about 30 years back when I was working in General Hospital. During that time, we had a liquor tragedy, and lot of people died during that methyl alcohol poisoning. During that time, General Hospital, we are having no facility for dialysis. Dialysis facility was available in Medical Trust Hospital. Dr. George K. Nanan was the consultant nephrologist there. He came to General Hospital and he offered even free dialysis to our patients. Lot of underwent dialysis, and we can save a lot of patients. We can save a lot of patients, and in that way, we reduce the mortality also. Another interaction we had in the government when I was in the government sector is during the outbreak of leptospirosis. അന്നൊക്കെ നമുക്കറിയാം SPM-നകത്തൊരു ചെറിയ പാർട്ടിയാണ് ലെപ്റ്റോസ്പൈറോസിസ്. ഷോർട്ട് നോട്ട് വല്ലതും ചോദിച്ചാൽ ലെപ്റ്റോസ്പൈറോസിസ് കോസ്റ്റ് ബൈ ഇത്ര വീൽസ് ഡിസീസ് അതറിയായിരുന്നു. ഡ്യൂറിങ് ദാറ്റ് ടൈം ദർ വാസ് ആക്ച്വലി ഒരു എപ്പിഡമിക് ആയി. ആ എപ്പിഡമിക് സമയത്ത് ഗവൺമെന്റ് appointed a committee to formulate the protocol. Being the government sector, myself, Dr. Silvanus, the late the senior physician, and Dr. George Kenan were the members. We formulated the protocol by the name Cochin Protocol for Leptospirosis Management, and the government asked us to conduct various awareness camps. I think we attended nearly 30 to 40 camps, not only camps, IMA programs to educate our doctors. And the interesting point is that he made all the work. He formulated everything, and ultimately I was nominated as the member of the International Leptospiral Society, and I went to Melbourne for the meeting. So that is one funny thing that has happened at the end. So George Genanan, he requires no special introduction. He popularized the early detection of chronic kidney disease in mid-Kerala. He did the first kidney transplantation in Kerala. He did the first cadaveric kidney transplantation in Kerala. And his team has already done more than 1,600 kidney transplantation through the network for organ sharing system. And he is a fellow of the Indian Society of Nephrology and also a fellow of the Royal College of Physicians. He's a good speaker and a good orator. You are going to see it. Then, with these few words, I invite Dr. Georgie K. Nair, best clinician, best orator, and a God fearing and a man loving person. Please, Dr. George.
Thank you, Giles, for the nice words which you have spoken. And I also nostalgia, all the good times in Cochin Clinical Society, leptospirosis, and also the methyl alcohol tragedy, which where we could save many people and their eyes. I also acknowledge the. I am very happy to come here for two reasons. One, Gilles had been telling me to come to the Physicians Club, and I am very happy to note that many senior physicians at that time, Rafiq, Ramakrishnan, Ajay, and Prasanna Umar, President, uh, and so many are there. Noble, Sunny, all are our contemporaries. And very nice to see that you have a very active meeting under the guidance of Prasanna Kumar and Gilles. And I won't take much time. The whole idea was how to prevent the progression of the kidney disease. I feel that as we are all drifting away to the replacement therapy by dialysis and transplantation, the preventive steps and prevention of progression, the responsibility lies now more with the physicians. And my talk will be clinically oriented and that too applicable for all of you. And I am hopeful that you are already practicing and then you can enhance the prevention of progression of CKD due to diabetes. With this few, and I thank Vilesh for the nice comparison of the CCBs, which he has done a lot of work, and we'll have a discussion. And now, with this, basically, my talk will be how to diagnose diabetic kidney disease. Urine examination, the relevance of IDR, correlation of creatinine with the EGFR, how to prevent progression of the diabetic kidney disease. What are the conventional things I will mention, but I won't go into the detail, and more specific drugs for the diabetic kidney disease. There are many, out of which three we will take. But Gilles has already mentioned RAS inhibitors, ARB and ACI, SGLT2 inhibitors, and the new drug finerenone. Basic thing is that proteinuria is the hallmark of diabetic nephropathy. When we do that, we are all doing a routine urine examination. It is better to do a microalbuminuria because microalbuminuria can detect early involvement of the glomeruli, endothelial damage, before the standard routine test or a dipstick test can detect protein. Why microalbuminuria is important? This is not very specific for diabetes, but is for endothelial damage. And diabetes is the most significant disease which affects the endothelium and produce microalbuminuria. So, in a diabetic with microalbuminuria, unless and proved otherwise, it is taken for granted that this microalbuminuria is due to diabetes. Is one of the indication to start RAS inhibitors. To a great extent, this is reversible. If not, it can be reduced and prevention of the progression to overt proteinuria and thereby going into renal failure. UACR is what is used for most of the clinical studies. Urinary albumin creatinine ratio. In a spot sample, you measure the creatinine and the albumin, and we'll come to the normal values. But still, gold standard is 24 hours urine protein. I always insist on 24 hours urine protein. Normally is 150 milligrams without urinary infection in an afebrile state, and that is a gold standard. More than that, even for donor selection, we discard that. This is a diagrammatic picture of the capillary GBM, glomerular basement membrane, and it is a very porous membrane like any other capillary but more porous, and the red lining is the slits through which the albumin, microalbumin, comes. When diabetes is the uncontrolled for a long time, the inside the endothelium the proteins are damaged, so they allow the microalbumin to come, and then overt proteinuria to 500, 1 gram, 3 grams, like that. This is the normal value taken from a American Diabetic Association reference. Normal microalbuminuria, either you do a spot or a 24 hours. So spot means less than 30 micrograms per milligram of creatinine, or 30, and then or 24 hours is less than 30 milligrams. 24 hours means morning 8 a.m. to next day 8 a.m. 30 to 300 spot collection is microalbuminuria relevant. More than 300 is macro. So that is the significance. And microalbuminuria, in the absence of any other detectable disease of the kidney, is considered as the earliest laboratory marker of diabetic nephropathy. This formula is for EGFR. Nowadays, patients are asking, my EGFR is this. Laboratories print it and give it. So, as a physician, you should know EGFR is not calculated only and not measured. And EGFR is by this formula. You don't have to mug it up. Then you have to just check the net or just save it in your mobile. And age and weight, serum creatinine, three factors will decide. Gender, there is a slight modification. Though GFR is 120, even for our healthy donors, we see only 100 plus minus 5. Anything above 80 is allowed for donation. So this EGFR is prognostic. Whenever they come to you and you measure the creatinine and body weight, you are doing routinely, and then you measure the EGFR and then note whether it's a decline or improvement. Another point I always emphasize, this is a fundamental of nephrology. What is the relationship between serum creatinine and renal dysfunction? See, it is unlike blood sugar, where is 110 is if you take normal, and 115 is you are a diabetic or needing diet control, etc. Creatinine, you see, when 100% of kidney is working, normal is working, when your EGFR is 100% for 100 ml, creatinine is below 1.4. You donate a kidney, 1.4 still, both the donor as well as the recipient, if it is a successful kidney transplantation. That means that you need 50% of the nephronal damage for the creatinine to increase. Till that time, there is a big buffer, and you can have albuminuria, microalbuminuria, macroalbuminuria, hematuria with normal creatinine. They all come under the category of diabetic disease if is a diabetic and due to diabetes which you are coming to, or nephropathy due to any kidney disease. Beyond 1.4 is like is going very rapidly. So very often patients will come and say, 2 months back my creatinine was 2.5. Today I had a fever and today is 4.5. Though the number has doubled, the deterioration is only around 5 or 10%. So this graph is very important to identify and explain to the patient where you stand, and you have to explain to the patient. So the relationship between diabetes, nephropathy and diabetic retinopathy is around 85%. Very often people in the absence of retinopathy, when you have proteinuria, you do a biopsy and then still diabetic changes may be seen. You know that there are two types of retinopathy, NPDR and DR. A good ophthalmologist can examine and tell you. So routinely every year, physicians should document whether they have or not through the help of their colleague ophthalmologist. So Jill said, when is the biopsy needed? You are all seeing diabetic patients, and usually nephropathy comes after 10 years. But Sometimes maybe after 5 years. Recently, we have seen a couple of patients who never had been detected as diabetes, but when we had proteinuria and did a biopsy, it was showing diabetic nephropathy. So these are all cases which are exceptional, but in general, 10 years of diabetes is what is usually predisposes for nephropathy. So when should we do a biopsy? Or when should you take an opinion from village or people like us? No diabetic retinopathy in the presence of proteinuria and or renal dysfunction. Massive proteinuria. Suddenly nephrotic range proteinuria, 3 grams, 4 grams, 5 grams. Microhematuria. Hematuria is not usually a feature of diabetic kidney disease. But if you get microhematuria, the incidence is only 13%. If it is microhematuria, you have to think of additional or another kidney disease. So a renal biopsy is needed. Creatinine worsening in short period of time, or any of these markers like ANA or anti-double strand DNA or ANCA are positive. Biopsy these days are very safely done by nephrologists. A gun is used, ultrasound guided. A tissue like this compared to that cotton gauze, you can see that thread. You can see what is the size, and this will give you about the various aspects of the kidney disease. Whether it was old, what is the present one, what should be the disease, what should be the future, etc. Now, coming to the second part, how to prevent the progression of diabetic kidney disease. So, conventional is the treatment is diet, which you all know. Look for reversible factor like stone, obstructive neuropathy, prostate with PVR volume, etc. Controlling of blood pressure is very important in the prevention of diabetic nephropathy. Control of blood pressure can be done with the RAS inhibitors, as Vilesh said. It may not be enough. Then you have to add additional medicine. Vilesh touched upon that, gave a good idea. And if you have to choose a CCB, he mentioned the advantage and disadvantage of various commonly used CCBs. And second is the other aspects are uric acid control, cholesterol control. They are all very important in the long run in preventing the progression of the diabetic kidney disease. Avoiding nephrotoxic drugs. Nowadays, so many medicines are there, so that they all have in combination or single, they have NSAIDs. NSAIDs are still one of the main culprit, and orthopedicians and or dental surgeons are notorious for writing this. So I always insist that you tell the doctor, you check in the net. If not, you are confused, you call me or my secretary, we will find out and tell you. Very often we tell them to say, don't take this medicine. I'm very sorry to say, because NSAID is still one of the drug in combination with paracetamol and all, worsening the kidney disease even in the post-transplant patient. Then radio contrast drugs. Unnecessarily, we should not subject them for radio contrast drug studies, but these days angiograms and CTs and everything is with contrast studies. Angiogram, we always say heart is important than kidney. If cardiologist says that angiogram is very important, life saving, go ahead, Max. So you may have a rise in creatinine, or you may need 2-3 dialysis. So what? You can save your life, and then we will save your kidneys. Minimize the diuretic use. Diuretic use produces hyponatremia, dehydration in many patients. It's only when it used in a higher dose. And vaccination is very important. I'm sure you all advise vaccination, not hepatitis B vaccination, flu vaccination, pneumococcal vaccination. They are all very important because all these infections nowadays, people, CKD patients, elderly patients die with respiratory infection, pneumonia, ventilatory support, and one of my colleague died few months back, or late Lassa Chandi. So all this, you get it from patients, you get it from colleagues, you get a pneumonia, somebody gets it worse, and you will end up with pneumonia and then ventilator, desaturation, and then that is it. You may come back, you may not come back. How to prevent progression of the diabetic kidney disease? More specific, what is now you all should use is three categories of drugs. One, ARB, ACI. That will be the first step of drug therapy in diabetic kidney disease, unless the renal failure is very advanced. Second should be SGLT2 inhibitors that will not only control the diabetes but also reduce proteinuria, prevent the progression of creatinine. Third new drug is finerenone. That is a little expensive. So we'll go through in under 5-10 minutes. More specific ARB RAS inhibitors, you all know that the RAS inhibitors give you efferent arteriolar vasodilatation. Angiotensin 2 produces constriction and inhibitors, anti-ARBs, they produce vasodilatation. When you give vasodilatation, the intraglomerular pressure comes down. And drugs like SGL2 inhibitors produce vasoconstriction of the afferent, thereby intraglomerular pressure comes down, and thereby proteinuria comes down, thereby subsequently the renal failure also does not set in. SGLT2 inhibitors, there are so many. What is available here is DAPA, EMPA, and CANA. DAPA is commonly used by all of us because there was main studies were done on that. Many people use EMPA, and we have to compare this and see which one is better. I have not done that, but I use DAPA mainly. I have seen many of our colleagues and physicians using EMPA. They act by preventing the reabsorption of glucose in the S1 segment. S1 means first part of the proximal convoluted tubule where the red arrows are shown. And also they have other tubuloglomerular feedback mechanism by which they prevent, they not only controlling the blood sugar but also preventing the proteinuria, and as I mentioned the effect on the arteriolar vasoconstriction, they produce intraglomerular pressure reduction. So they have that is a main mechanism by glucose excretion and blood sugar control. They have got modest diuresis along with the glucose. Water will go. Some people will have significant diuresis with SGLT2 inhibitors and weight loss, better BP control, and uric acid control. There are many studies, EMPA, outcome, Canvas study, Credence study, DAPA CKD. These are the four main studies which I came across for the SGLT2 inhibitors. All of them have shown, especially DAPA CKD study has shown decrease in the cardiovascular mortality and decrease in the progression of the CKD. That is very important. Initially, there is a 5 ml per minute reduction in the GFR. Don't worry, get worried. If it consistently goes, you have to withdraw. That happens with even RAS inhibitor. When you start any of the ARBs or ACI, there is a dip in the GFR as evidenced by rise in creatinine. If it is not more than 20%, then you continue. It will steady, and then renoprotective effect will be more. Finerenone is a new drug which many companies are coming with that. It is expensive, but we should know about that. Basically, there are three ways by which the diabetic CKD can be. There are three rounds. One round is not very clear. One is a hemodynamic effect. Hemodynamic effect is reduced by control of blood pressure. RAS inhibitors as well as CCBs and the rest of the antihypertensive spectrum, your blood pressure should be controlled. ARBs and CCBs, some of the CCBs have got a renal-specific effect, which Vilesh also mentioned about that. Ultimately, blood pressure should be controlled. It should be custom-made so that the blood pressure should be controlled and hemodynamics should be taken care. Metabolic control should be with oral hypoglycemic agents like SGLT2 inhibitors or with insulin or any other drugs, depends upon the creatinine. Metformin, though was held responsible for lactic acidosis and all, Nowadays, many of the people use it till creatinine is around 2.53 without any much problem. So it is a good drug, especially in obese people and refractory hyperglycemic condition. The inflammation and fibrosis is reduced by drugs like finerenone, and so there is a less cardiac and kidney fibrosis through the anti-inflammatory action by the finerenone. If you compare finerenone, spironolactone is a poor man's finerenone. They both, it had been used by cardiologists predominantly because of the hyperkalemia due to or potassium retention due to spironolactone. We had not been using it much. For cardiac failure, they always use as a diuretic. It can be used even in kidney failure, but monitor the potassium. Potassium should be kept always below 5. Compared to spironolactone, finerenone is highly selective. You can look at the second column. It is more highly selective. Finerenone showed lesser risk of the effect was more pronounced, and also the duration of action is a short half-life. So because of these two reasons, finerenone is a more better drug than aldosterone antagonist spironolactone. There are many studies like Fidelio study and Figaro study. They all have shown that it is beneficial both for cardiovascular mortality reduction as well as CKD progression in both the studies. And so therefore the cardiologists use a lot. So to conclude about finerenone study, the finerenone is approved in India now with the same indication as that in US FDA. Finerenone is indicated in adult patients with CKD associated with type 2 diabetes, not in type 1 diabetes, to reduce the risk of sustained EGFR decline, end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure. So finerenone is being used by cardiologists more than physicians or nephrologists. But when we use it, what are the things we should be careful? Potassium. We are already patients are on prone for hyperkalemia. You may be giving them ARB or ACI, which also produces hyperkalemia. In addition, finerenone also produces hyperkalemia. So we have to be careful about that hyperkalemia, especially initially when you initiate them on that, you have to monitor the potassium more frequently. If potassium goes up, you reduce the dietary potassium. You can withdraw one of the drug, depends on the hemodynamic effect or the anti-fibrosis effect, whichever you feel. Usually we withdraw ARBs and ACI, whatever they are, and compensate with the CCBs, and then continue with finerenone. If still hyperkalemic, you can give them potassium binding powders, and but more important is potassium should be kept below 5, if not below 5.5. Above 5.56, ECG changes and hyperkalemic problems do come in the heart, arrhythmias and various things. So it is better to keep it because we are not monitoring every day. We'll be checking once in 2 weeks, if not once a month. So, ladies and gentlemen, what I had been telling you is how to prevent, how to diagnose diabetic kidney disease. What is the significance of 24-hour urine protein? If a patient is busy, they have no time, do a UACR, urinary albumin creatinine ratio, a spot sample comparing both. You suspect diabetic nephropathy, check the eye for DR. If conditions which we enumerated and if they don't fit into a diabetic nephropathy and you think other causes of maybe there, you refer to a nephrologist for a biopsy, and biopsy will tell the truth, and pathologists have always the final word. And then once you diagnose diabetic nephropathy, points to look at is hemodynamic control, very important, metabolic control, you decide what medicines you should give, OHA or insulin should be controlled. Certain advantages are for this type of drugs. Then fibrosis and reduction in the proteinuria and decline in the GFR and worsening of the renal function with the use of finerenone. Finerenone is expensive. 10 milligrams and 20 milligrams cost the same. So what we use is tell them to buy 20 milligrams, divide into two, and then take it. Monitor potassium. So thank you very much for this nice occasion. And Vilesh and myself will be happy to answer your questions, and your experience can also be shared. Thank you, Jens. Thank